presented case demonstrates tooth preparation, laboratory fabrication, surface preparation, adhesive protocol, and finishing of an onlay restoration. The teeth were restored using a new formulated indirect laboratory composite resin system, Belglass Next Generation. In this clinical and laboratory protocol, a 55-year-old male presented with a defective amalgam restoration with a fractured buccal cusp and recurrent decay on the maxillary left first molar. The preoperative consideration included custom shade selection, a hand-drawn occlusal and shade diagram, and caries assessment using a caries-detecting dye and quantitative light-induced fluorescence. The mesiolingual fissure at the cusp of Carabelli was evaluated with a light-induced fluorescence using the Diagnodent by Cavo. This system relies on fluorescence diagnosis of caries, in which the fluorescent properties of enamel and dentin are altered by mineral loss. This device aids in monitoring or assessment of caries and is a useful adjunct to diagnosis of fissure caries. The Diagnodent scale reading of 9 indicates no caries present and the region should be monitored. The proper shades of composite and tints were selected and their specific orientation was designated on a shade diagram prior to rubber dam placement. Shade selection should be done prior to rubber dam placement, since dehydration of the teeth can result in an elevated value and may cause the selection of an incorrect shade. The following clinical protocol uses the indirect restorative technique, which requires 2 appointments. The preparation was performed according to the aforementioned onlay preparation design. Sufficient reduction of the fractured distobuccal cusp and the undermined distolingual cusp were made to allow an adequate restorative material thickness while providing space for an incorporating fibers and optical integration. Before removal of the rubber dam and impression taking, the preparation was cleaned with a 2% chlorhexidine solution to remove potential contaminants. I used Conceptus by Ultradent products. The preparation was etched for 15 seconds with 37.5% phosphoric acid gel, rinsed, and lightly air-dried, leaving the dentin substrate moist. In this procedure, I used gel etchant by Kerr. This product, OptiBond Solo Plus, gives optimal bond strengths with a wet dentin substrate. A thin layer of the single-component adhesive OptiBond Solo Plus was applied to the wet substrate, air-thinned, and light-cured for 15 seconds. This hybridization layer seals the dentin tubules and protects the pulp from the invasion of microorganisms and reduces sensitivity during the provisional stage. This SEM reveals the hybridization layer. Note the dentin tubules are sealed. An accurate polyvinyl siloxane impression of the preparation was taken using Take 1. Notice the impression defines all cavo surface margins. A direct provisional restoration was placed with a matrix band using a light-cured semi-flexible material, and the occlusion was inspected. In this procedure, I used tint fill by Kerr. A model of the opposing dentition and an inner arch occlusal bite registration was conveyed, with 35mm photos of the shade tab comparison to the laboratory. In the laboratory, a dye stone is mixed with the correct powder liquid ratio under vacuum, and the impression was poured for a master cast and a working cast and mounted on an articulator. The working model was mounted on dies to facilitate the layering process. The margins of the onlay preparation die were trimmed and marked with a red liner. A reinforcement fiber is pre-measured in a mesiodistal direction of the tooth preparation. In this procedure, I used Construct by Kerr. A Construct resin is dispensed onto the mixing pallet, and the pre-cut Construct reinforcement fiber is worked through the resin until it coats the fiber. An application of a thin layer of A and B separator or rubber sep is applied to the die in any part of the model that may come in contact with the Belglass Next Generation, and then air-dried. This layer acts as a separating medium and die spacer. A thin layer, 0.5mm of an A2 shaded flowable composite is injected and uniformly distributed with a ball-tipped instrument using an M1 by Ufridi, and then it is light-cured. This thin layer provides optimal internal adaptation to the pulpal floor of the preparation. An A2 shaded opacious dentin using Belglass Next Generation is placed as an artificial dentin layer. The pre-measured reinforcement fiber is incorporated into the uncured dentin layer and light-cured. The selection of an opacious dentin allows the fibers to be completely disguised, and the initial thin composite layer prevents the fibers that are subsequently incorporated from being exposed during surface treatment, which could cause tissue irritation, water absorption, change in color, and the potential elimination of the material. Subsequent increments of opacious dentin are placed to develop the cusp and inclined planes. Note, I use a number 4 sable brush to smooth and shape the composite. A smooth surface is crucial because surface irregularities could interfere with the placement of tints for internal characterization. A modeling gel is applied to the tip of the brush to reduce surface tension, which enhances the adaptation. This technique reduces the possibility of entrapping bubbles and ensures optimal adaptation of the resin material to the adhesive interface. The internal dentin core was developed by adding opacious increments of A2 shaded composite, which are placed circumferentially around the dentin core. It is important to observe the required boundaries of the artificial enamel layer and not trespass into this zone. Remember, always anticipate your final result. An indentation was developed around the central dentin core with a long-bladed instrument. This will allow subsequent placement of translucent dentin into this region, which creates an integration between layers of different colors and opacities, and the developed structure is light cured for 40 seconds. A2 shaded translucent composite increments are applied corresponding to the shade mapping diagram. Each increment was placed and shaped with a long-bladed instrument around the existing dentin core. The developing anatomical contours were smoothed with a number 4 sable brush and then light cured for 40 seconds. Translucent C1 shaded composite increments were placed on the occlusal planes and in between the dentin core and the tooth structure corresponding to the shade mapping diagram. Each increment is placed with a long-bladed instrument, contoured and shaped with a curved instrument. The anatomical contours were developed incrementally and smoothed with a number 4 sable brush. Additional increments of A2 shaded translucent composite were placed along the inclined ridges and planes and again smoothed with a number 4 sable brush. Before polymerization of the final dentin occlusal layer, an invagination is defined with a long-bladed instrument forming a central, lingual, and a buccal groove. An infinitesimal amount of brown tinted resin using color modifier is diluted with an untinted resin and applied with an endodontic file into the pre-developed invaginations according to the preoperative shade mapping diagram. The layers are compressed together with a curved instrument, creating a fine line of stain from the base of the invagination to the occlusal surface and light cured for 40 seconds. These tints should be polymerized prior to the placement of additional stratification materials to stabilize the characterization and prevent mixing of colors. An ochre tint is diluted with an untinted resin and applied into specific occlusal and lingual grooves corresponding to the shade mapping diagram, and the chroma diluted with untinted resin and light cured for 40 seconds. This color provides a warm internal hue. An infinitesimal amount of diluted gray tint was placed on the distal marginal ridge area and other specific regions corresponding to the shade mapping diagram to give an illusion of translucency and then light cured for 40 seconds. A white tint is diluted with an untinted resin. Referring to the shade mapping diagram, the resin is placed with a fine tip of a double-aught sable brush along the inclined planes and cusp tips and light cured for 40 seconds. The artificial enamel layer includes 2 different shaded composite resins. A cuspal enamel layer is placed as the outer thin envelope on the buccal and lingual surfaces and shaped with a long-bladed instrument and smoothed with an artist sable brush. A light enamel shaded composite is placed in small increments over the developed anatomical contours as a thin occlusal enamel envelope, shaped, contoured, and smoothed with an artist sable brush. It is important to anticipate your final result before you get there to prevent over-contouring, since shrinkage of the enamel layer is minimal during the final heat and pressure curing. Over-contouring will require increased finishing time and a reduction in correct dentin to enamel proportions. Developing the restoration in increments and considering the occlusal morphology and occlusal stops allows the clinician to minimize finishing procedures and results in the restoration with improved physical and mechanical characteristics with less microfracture. After polymerization, the onlay is removed and is placed on a separate working die, and the final adjustments and contours of the margins and proximal surfaces are completed and smoothed. The onlay remains on this die and is placed in the curing oven at 135 degrees centigrade at a pressure of 60 to 80 pounds per square inch or 41.3 newtons per centimeter squared in a nitrogen atmosphere. The elevated temperature and nitrogen gas increase the polymer conversion, and the pressure allows the oxygen to be purged out of the system in 3 cycles. The die or mounted cast is placed into the Bell Glass Next Generation Curing Unit chamber. Lock the latch and select either the 10-minute curing cycle for single units or the 20-minute cycle for multiple units. The final restorative phase is accomplished by contouring and finishing the restoration, which is critical for enhancing the aesthetics and longevity of the restored teeth. The laboratory finishing process begins with the adjustment of contacts on the solid tissue model. I use articulating paper to mark the premature contact. Then it is placed on the working die and adjusted. The distal surface can be adjusted with a Composite Pro one-step wheel by Brasseler. Its flat edge is excellent for minor adjustment while polishing the contact zone. Gingival and proximal contouring is accomplished with a short, tapered, straight-edge finishing burr. I use the ET3 by Brasseler. Excess composite can be removed with an 8-fluted, while a sequential increase in the number of flutes can be followed to achieve a smooth surface. Also, the gingival and proximal margins can be finished with coarse to extra fine aluminum oxide disc. I like the Kerr-Have OptiDisc. For shaping and contouring the occlusal surface, I use the egg-shaped finishing burr, the OS1 by Brasseler, or the 7406 and 9406 blue-white diamond by Kerr, with a sequential increase in the number of flutes. The shape of these burrs conform to the appropriate curvature of the morphological occlusal contours of the restoration. The final polishing is initiated with pointed Composite Pro brushes by Brasseler on the occlusal grooves, and the silicone rubber points which allow surface defects to be effectively eliminated. I use a Diacomp pre-polish and high-shine silicone point by Brasseler. The final polish will impart a high luster or surface reflectivity on the restoration while maintaining the existing texture and surface anatomy. For final polishing, I use a goat hair wheel and polishing paste applied in a circular motion at conventional speed. These loose abrasive pastes allow anatomical details to be maintained while imparting an enamel-like appearance to the restoration. A final polishing surface gloss can be achieved with a dry cotton buff from the Cerashine kit by Brasseler. I use an intermittent circular staccato motion applied at conventional speed. Note the aesthetic appearance of the surface of a composite restoration is a direct reflection of the instrument system used. The surface of laboratory process composite resins is highly polymerized with minimal unreacted free end radicals for bonding to the resin cement. Several surface treatments have been advocated to promote adhesion between the resin cement and the indirect composite restoration. My standard cementation protocol for laboratory process composite resins includes micro-etching the inner surfaces of the crown with cojet sand, followed by silane application to restore any coating on the original fillers that may have been removed by sandblasting. For more information on this procedure, please review the indirect clinical video and/or supplemental readings provided at the end of the video. On the second appointment, the cavity preparation was cleaned using hand and sonic instruments and rinsed thoroughly to eliminate all abrasive particles. The restoration was tried in for color evaluation and marginal adaptation prior to rubber dam placement. After rubber dam placement, the preparation was cleaned with a 2% chlorhexidine solution to remove potential contaminants. I used Conceptus by Ultradent products. The preparation was etched for 15 seconds with a 37% phosphoric acid semi-gel, gel etchant by Kerr, rinsed for 5 seconds and lightly air-dried, leaving the dentin substrate wet. A single component adhesive OptiBond Solo Plus with activator was applied with an applicator for 15 seconds with a continuous motion, reapplying every 5 seconds, air-thinned and light-cured. The restoration was cemented with a yellow dual-cure composite resin cement Nexus 2 by Kerr. The cement was mixed and loaded into a needle tube syringe tip and injected into the entire preparation. The onlay is gently seated into place. The excess cement is removed with a sable brush and the interproximal is flossed. It is imperative to leave a residual amount of cement to prevent voids and to compensate for the polymerization shrinkage of the cement. The restoration was polymerized from all aspects, facial, incisal, lingual, and proximal surfaces for 60 seconds, respectively. During the final restorative phase, minimal finishing and polishing is required since the laboratory restorative development was orchestrated with the final result in mind. The occlusal anatomy is refined with an egg-shaped finishing burr, a 9406 blue-white diamond by Kerr, or the OS1 by Brasseler. This procedure usually requires only the 30-fluted burr. However, if an 8-fluted burr is utilized, a sequential increase in the number of flutes is required. The interproximal finishing is performed with a needle-shaped finishing burr and ET6 by Brasseler. Excess composite resin can be removed with a number 8-fluted egg-shaped finishing burr at medium speed with air coolant, light intermittent pressure, and a staccato motion. A smooth surface can be achieved by following a sequential increase in the number of flutes. The lingual and buccal aspect of the posterior restoration can be finished with a shorter version of the tapered needle-shaped finishing burr, the ET6 by Brasseler, which allows adequate space in the posterior region of the oral cavity. Prior to final polishing, the restoration and the adjacent enamel can be re-etched with a 37.5% phosphoric acid semi-gel, rinsed and air-dried. A composite surface sealant, OptiGuard by Kerr, is applied and cured to seal any marginal gaps or microscopic porosities that may have formed during the finishing procedures. The final polish is initiated with Diacomp silicone rubber points, pre-polish and high shine by Brasseler. These silicone points are composed of aluminum oxide particles that permit surface defects to be effectively eliminated. However, it is imperative to use them after the surface sealant is applied, because polishing the surface of the restoration prior will contaminate the surface and affect adhesion of the composite surface sealant. After final polishing with composite polishing paste, the post-operative intraoral occlusal view of the completed restoration reveals an optical integration of the composite resin with the existing tooth structure. Note the marginal adaptation of the indirect composite restoration at high magnification. This laboratory and clinical presentation has provided a detailed description of the fiber reinforcement, correct laboratory implementation of restorative materials and techniques, adhesive surface preparation, adhesive protocol, and finishing procedures to develop form, function, and natural aesthetics by integrating laboratory processed composite resin with the existing natural tooth structure.